Thank you. I'm delighted to be here. And so people often ask me, how did we come up with the name Jairus? And my ethnic background is Greek. And so Jairus, how many people know what that means in Greek? Any show of hands? So Jairus means Yeros, which is older adult in Greek. So there you go. That's your pearl for the day. And so I've been funded previously by Amgen and Eli Lilly. I work for McMaster. The guidelines received support from CIHR, and then the Ontario Ministry of Health and Long-Term Care in Ontario funded the long-term care component of the osteoporosis strategy. So when you have vested interests, Gord Guyot had published an article in the Annals of Internal Medicine recommending that you work with a non-vested epidemiologist, and Dr. Nancy Santesso was the grade methodologist who worked with our group. And how many people have heard of GRADE? And I apologize to the other side of the group that's watching us in the audience. Anybody heard of GRADE? Some people. So this is a whole new approach to guidelines, and I'll talk to you a bit about why it's particularly interesting in aging research. So our objectives are to improve fracture risk assessment and identification of older adults at high risk. What are some challenges in the long-term care sector in particular? What are pharmacological and non-pharmacological approaches and quality measures for the care of older adults? So the prevalence of fractures in long-term care is 2 to 4 times higher than that of those in the community. 1/3 of older adults who experience hip fractures are in long-term care. The good news, as part of the strategy, we evaluated using provincial data. In Ontario, only in long-term care have hip fracture rates gone down in the past 5 years. That's the only sector. Also important to know is that 36% of those older adults in long-term care have spine fractures that are often missed. And what is your clinical clue? Is somebody that's curved over like this, you need to think that 40% are going to have a fracture. Those little spines that are bent over and the spine is hitting the wheelchair cushion, at the thorax, and they're getting decubiti or pressure ulcers, that's a first cue. And another take-home pearl is, in order to reduce fractures in either the home care, older adult, frail person, and in long-term care, you need to look at falls and osteoporosis risk factors to reduce fractures. You cannot do one or the other if you want to reduce fractures. Now, Devora Greenspoon, it's a great YouTube. If you go to the Jairus website, she's our patient story that talks about why it's important to prevent fractures. So this is an older adult who's actually cognitively intact after her delirium cleared and ended up in long-term care, talks about her story about the impact of losing her independence due to fractures. And it's a nice short story. She was featured in the Globe and Mail when the guidelines were published. So what is the impact of fractures? These videos were filmed in the Schlegel villages, Wentworth Heights in Hamilton, and they were very gracious, the seniors, in volunteering for the videos and the staff. So what is a risk factor for a fracture? Having had a prior fracture. So that's a take-home pearl. Ask if they've had a fracture after the age of 50. As Mrs. Greenspoon talks about in her video, is the quality of life is that you lose your independence. Whether you're in home care, long-term care, and you're frail, not being able to get out of the chair, transfer independently, really does affect your quality of life. Up to 20% will end up in long-term care, and we know now currently with our dementia strategy that we can keep a lot of folks in the home with dementia, but once they fracture, that is really a game-shifting moment. For those we know that hip fractures also have a mortality risk. If you're from long-term care, it's about 40%. So that really is an important take-home, is it may shift us into thinking that some of these folks we need to take a palliative care approach when they come back. So, who is the highest risk for breaking mortality post-hip fracture? Those older than 90, those who have not had surgery, very severe cognition on the cognitive performance scale using the MDS-RI. But just to point out, it's not a terminal diagnosis. In long-term care, now this is US data published in JAMA, it ranged from 70 to 1,000 days post-hip fracture. So really, and we're going to talk about fracture interventions, but what's very important to realize in Ontario, of all seniors, this is community, long-term care, and home care, only 20% post-fracture are getting appropriate treatment. And it's dropped since 10 years ago. Long-term care is the only sector that the care has improved. So think about in the community when you see folks, if they've had a fracture, you're seeing them in dementia clinic. Dementia is a risk factor for falls and fracture. That's a targeted group that we need to focus on. So post-fracture, that's automatically with hip a high-risk patient. So what are challenges in long-term care? Dementia, dysphagia, renal problems, not having an appropriate fracture risk assessment tool, or all of the above? It's all of the above. So we've developed a fracture risk assessment tool. So the current fracture risk assessment tools are called CAROC and FRAX, developed for the community. They predict a 3% fracture risk over 10 years. The tool we've developed with MDS-RI that we've, in collaboration with John Hurdes from the University of Waterloo, predicts a 12% fracture risk in a year. So we're able to really identify who's going to fracture in long-term care, and we're just working at launching that now. So current challenges is that fracture risk assessment tools haven't been validated in this cohort. Dementia, swallowing difficulties, chronic renal disease is a challenge, particularly with some of the medications we prescribe. And as I mentioned, research and guidelines regarding assessment and treatment of these folks have not included individuals with multiple comorbidities and a shortened lifespan. And I would have to say for a lot of guidelines in chronic diseases, the complex individual in long-term care and the complex individual in home care populations have not been included. And we'll talk briefly about barriers. Now, why we've expanded to say the frail older adult, long-term care, home care, and the retirement home is many times that same person that's a long-term care patient can reside in their home or in the retirement home. And that often is that the long-term care sector has said it's that individual, that complex, frail individual, rather than perhaps the setting. So some of the challenges are patient factors. We've got complex patients on a mean number of drugs of about 10. Practice-related, there's difficulty applying tools, whom to treat, side effects, and often the process and structure when to do things in long-term care is challenging because they have a lot of mandates right now. And there's high turnover in the environment. Physicians are often off-site. Sometimes there's too many physicians making things a challenge. Just going to skip that slide. So what are important risk factors for fracture except, is it prior fracture? And we said already yes. What sites do we mean? Typically it's spine, hip, long bones. It's not typically your hands, skull, or your ankle. Anti-inflammatories, dementia, psychotropic drugs, or falls. And the correct answer is B, anti-inflammatories are not associated with falls and fractures. So admission to long-term care, the highest risk time is the first 180 days for fracture. That's the most important time. Number of things, you've got a new environment and often an individual who has dementia. You also have the challenges that a number of these individuals may not have been taking their drugs. And all of a sudden we're prescribing that whole list, and they have, they'll have a postural drop or they'll become delirious because we know many of these patients were not taking the drugs prescribed. And so this is some of the findings we found in the MDS-RI tool. So what's the goal of the 2015 fracture prevention recommendations? These are the goals, and because of the grade process, you really have to include the end user, which is families and residents. This was their goals, which was decrease in mobility, pain, transfer to hospital, and improve quality of living for residents. There's no mention of improving your bone density. These are their goals. And the recommendations. As I mentioned, really need to integrate falls and osteoporosis assessment if you're ever hoping to reduce fractures. How were the recommendations developed? So this is the grade approach. Before we used to say guidelines had grade A evidence, grade B evidence, grade C. Now the grade approach is accepted by the World Health Organization. You look at the quality of evidence, which were the old guidelines. But now you have to look at the harms and the benefits, the values and preferences of the end user. That doesn't mean the doctors or the nurses or the healthcare team, it means the patient and their families, and costs. These guidelines were highlighted by the American Annals of Long-Term Care and the Annals of Internal Medicine because they use this approach. And so how can the recommendations be interpreted? Now, this is challenging. It was challenging for many of the authors who are part of this process. And we had a wide interdisciplinary group from across Canada. So strong recommendations mean most individuals in this situation would want the recommendation. Most individuals should receive the recommendation. For conditional ones, we say we suggest. Majority of individuals in this situation would want the course of actions, but many would not. And it means that the clinician is having to guide the resident. Also, we look at the evidence. High is we are confident the true effect lies close to that estimate of the effect. Moderately, the true effect is likely close to the estimate, but there's a possibility that it may be substantially different. Now, why this is important is many of the pharmacological clinical trials were not in the long-term care setting. So some of our evidence is moderate and low as a result. So how do we assess for high risk of fracture in long-term care? Unfortunately, the tool yet for MDS-RI was not yet available when we published the guidelines, but we basically divided two groups, high and those not at high risk of fracture. So if you were to use the FRAX, because people ask me, well, what about this tool FRAX and CAROC? If we use those tools, if you use the FRAX that includes the hip bone density, over 80% of all individuals in long-term care would be considered high risk. So that's including too many folks. And people then say, well, you don't have to use a bone density. What about FRAX with the BMI? It is actually even worse. It would be 90% of individuals at high risk, everybody. So that's really not helpful for the clinicians. So with our current tool that we'll be using with MDS-RI, it goes down to about 55% of those in long-term care would be considered high risk. So on admission, asking prior hip fracture, prior spine fracture, have you lost 6 centimeters of height? So does the patient look like this when you're doing your admission assessment? And if you're ordering a chest x-ray for other reasons, it's a good opportunity to say, rule out compression fracture. Right on the chest requisition, it's very cheap. More than one prior fracture, have you broken your bone after 50? The patient and their family are both there, that's a great opportunity. Steroids, have they been on steroids, and have you been on osteoporosis medication? Anybody admitted on osteoporosis medication, at this time we deem them high risk because they had been on assessment in the community. The other very important things to talk about are high-risk medications. Now, in our meta-analysis that we published, there wasn't enough great evidence, but the high-risk drugs that you should be thinking about is psychotropics. SSRIs have been linked to both falls and fractures. And in Canada, we were the first group to identify it with our CAMOS publication. Drugs that are PPIs, what we call proton pump inhibitors, are also a reason that patients fracture. So important to reassess steroids, PPIs, psychotropics when they're on admission. Now these tools are available both on Osteoporosis Canada and the JERIS website. They're also, I know that there's a big French community in this LIN and RGP area. So if you go to Osteoporosis Canada, we have the tools in French, we have the PowerPoints in French, and we have the link to the guidelines in French. We translated the guidelines. So fracture risk assessment on admission, the nursing staff, the long-term care has said that that's a really key time to ask about risk, to think about this. Prior fracture, steroids, were they on treatment? Think about the chest x-ray ordering, rule out compression fracture. A chest x-ray typically goes down to T12, where a lot of the fractures happen. So T12 is where you turn, L1 is where you turn your spine. So if the answer is yes to any of these, they're high risk. What are the recommendations for calcium and vitamin D? We recommend for all residents the dietary interventions to meet the recommended RDA for calcium in Canada, and that's 1,200 milligrams. That's 3 servings of dairy or dairy equivalents. There's been no increase in cardiac events with dietary calcium, and that may be because you take it usually with protein and fat. So things like chocolate milk have the protein, fat already there. So for residents who are at high risk but can't meet the RDA, we recommend daily supplements of up to 500. More than that is associated with constipation and bloating, and is not an ideal option for older adults. For those who are not at high risk of fractures, we suggest, so this is a conversation. So, how many hip fractures does it save? So we published, just for folks to know, we published the guidelines in CMAJ, which are about a 10-page document, but online is all the evidence tables that shows, what are the confidence intervals around the evidence. For residents at high risk, 15 out of 1,000 fewer hip fractures. For residents not at high risk, it would be 5 per 1,000 fewer hip fractures if you did this. And this is also in keeping with the US, the Institute of Medicine report. I just wanted to highlight is that the maximum dose for vitamin D that they published is 4,000, where you don't have to monitor vitamin D levels. But you can see calcium for those over 70, 1,200 dietary, maximum upper intake 2,000. For D, they've said 800, maximum 4,000. Over 4,000, you need to start monitoring for adverse effects. And I know a lot of my patient seniors in the community are taking a lot of vitamin D. So what about exercises? If you go to Osteoporosis Canada's website, there are great videos for the frail older adult for falls prevention and also tear-off sheets. So important because I think sometimes we always reinvent the wheel. For residents at high risk of fractures, we suggest balance, strength, and functional training only when part of a multifactorial intervention to reduce falls. And that is a bit of a mouthful. It took me a while to get my head around this. So the challenge is that when you take a high-risk individual who's been relatively immobile and you mobilize them, they have a higher risk of falling and breaking on those fragile bones. So post-hip fracture, we walk them down that corridor. If we don't look at that other falls risk factors, they're more likely to fall. And this finding was actually even in younger women. Me Too Majumdar in Edmonton did an intervention with women with wrist fractures where they said, in one group, we're going to tell them to exercise. In the other group, we're just going to say, go about your normal life. And it was just handouts. The group that started exercising fell and broke their wrist more often post-wrist fracture. So important to think about. For those not at high risk, we suggest balance, strength, and functional exercises to prevent falls. So those for high risk, 85 will fall more if you don't look at their other falls risk factors, if you mobilize them. For those not at high risk of fractures, 660 fewer falls per 1,000 older adults. So what we're saying is, don't just walk them, make sure there's balance and strength training, because actually walking doesn't reduce falls. And if they're high risk, you need to look at their other falls risk factors. So here's an example of balance exercises for those of us in the community, standing, using a chair for semi-tandem approach. The stance, the things that we do in the neurological exam as clinicians are the same exercises that you show patients about balance. And those that are really in long-term care or very frail, seated weight shifting. And Laura Giangregorio is the scientist that developed these at the University of Waterloo, who we collaborated with, and she won the Bloomberg Award from McGill because of her work on physical activity in the frail and older adults. What about strength training exercises for lower body? Here are some examples, but you can see even in the senior seated knee extension that this is possible in long-term care. And it doesn't always have to be a physiotherapist. It can be a physiotherapist who's mentored a physio aide or some other healthcare team member. Here's examples of strength training for upper body. Again, no matter if you're chair-bound or mobile, there's different options. What about hip protectors? And I think this is an area that's really evolving with technology. We're starting to see very interesting concepts like belts, things that will expand when you fall, sensors, and the hip protectors that we're seeing now, I think in 10 years are going to be gone, maybe even 5 years. For residents who are mobile at high risk of fractures, we recommend hip protectors. For residents who are not at high risk of fracture but are mobile, we suggest. So if somebody's falling frequently and has had Parkinson's or strokes, who are fall risk but aren't high risk fractures, you may want to think about it. In the community, the hip protector evidence has been negative, and there's a number of reasons. It may be that the risk of hip fracture is not as high as long-term care, and adherence is an issue. So if we use them, it'll reduce hip fractures by 18% in the frail elderly, so 11 fewer hip fractures per 1,000. What about multifactorial interventions and recommendations? There's no evidence that at this time the falls interventions we do in long-term care reduce fractures. So that's really important take home. So if somebody's high risk, you have to do the falls and think about the pharmacological approach if you really want to reduce the hip fractures. And so what do multifactorial interventions mean for falls? It's a combination when we looked at the literature. It's a bit of a geriatric black box, medication reviews, environmental hazards, use of assistive devices, exercise, management of incontinence, and educating the staff. So for all residents, we suggest multifactorial interventions, individually tailored to reduce falls and fractures. The reason we say suggest is that the evidence, even in long-term care, isn't that great. So, for number of falls would be 660 fewer falls per 1,000, and for people who fall at least once per year, it's 55 fewer people would fall. Number of people who have had a hip fracture in 1 year, 10 per 1,000, but the evidence and the confidence intervals are wide. So these interventions, we're not really sure that they really prevent fractures. And there's a new CADITH report that's just been available that really doesn't support as strongly calcium and D in long-term care for the high risk for all residents. And it's very much in keeping with our results, but they presented it a little bit differently, just so that you're aware, is that calcium and D alone for the high-risk individual will not reduce fractures. It's an important adjuvant. So for high risk, again, part of the challenge with this group is there's wide confidence intervals. Their findings and ours are very similar. So for high risk, we're saying 1,200, try and get it through your diet, engage your nutritionist and your dietitian in long-term care. If they can't meet, so high risk again, remember fractures, prior osteoporosis. If they can't, 500 supplement, vitamin D. We've said up to 2,000 because of the Canadian population, many are vitamin D deficient. Hip protectors for those who are not mobile. And this is all part of a one-page algorithm with an order set on the flip side if you go to the websites. So, what about medications? When we calculated the effects of benefits and harms, you need to survive at least 1 year to have the benefit of medication. And at that time, we did the meta-analysis that there is a difference in terms of fracture. You do develop the benefit. But shorter lifespan than that is not, you wouldn't derive the benefit. So for high-risk individuals, alendronate 70 milligrams once weekly or residronate 35 milligrams once weekly. And all of these medications will reduce fractures at 1 year by approximately 40 to 60% depending on the site. What we find in long-term care is that many of the medications, when we've done focus groups with nursing staff, they're crushing these drugs, and which increases the risk of esophagitis. You need to take them on an empty stomach unless it's residronate DR, but you do need to sit upright for 30 minutes after the administration, which can pose a challenge. But this is very cheap, pennies a day, they're all generic. So this is the first line that we've recommended. And there is evidence, they've had good studies in long-term care, Susan Greenspan, around maintaining bone density, but the fracture evidence is the community, and that's why we've gone moderate in the evidence portfolio. For those whose creatinine clearance is less than 35 or 30, depending if it's alendronate or residronate, we've said is contraindicated. So in long-term care, we've developed an app actually with Medical Pharmacies Limited adjusting drugs automatically for long-term care residents. But it's really an important caveat for a lot of our frail elderly people that your pharmacist calculates the creatinine clearance, or residents, if you use your app to calculate it, because we're often giving inappropriate doses for this frail group. For high-risk individuals who have difficulty taking oral medications, we recommend denosumab 60 milligrams twice yearly. It's like a flu shot, subcutaneous, easy to give in long-term care. For those who the other option is zoledronic acid, 5 milligrams IV yearly. It's an intravenous, sometimes challenging in long-term care. it should be infused over at least half an hour to 45 minutes. And the most common side effects with that drug is a flu-like reaction that can be decreased by 50% if you're taking Tylenol. So what are contraindications? Denosumab can be associated with low calciums. It may worsen, especially in patients with renal impairment. So these are potent drugs, need to make sure, and a lot of patients that are vitamin D deficient have low calciums. So post-hip fracture on the inpatient units, we often give them a week of at least calcium and D before we initiate the medications. Zoledronic acid is contraindicated in patients with creatinine clearances less than 35. And just so you're aware, all these classes of drugs, which are the anti-reabsorptive family, the bisphosphonates, denosumab, can be associated with osteonecrosis of the jaw and atypical fractures. So osteonecrosis of the jaw is not a painful jaw, it's actually an ulcer in the jaw, and an atypical fracture is a subtrochanteric fracture, which often involves the cortices. It's not all subtrochanteric fractures, but the risk of these fractures is very rare. 1 to 10 to 1 to 100 over 100,000. So for every 100 hip fractures these drugs prevent, it may be associated with one subtrochanteric fracture. So pretty rare. And they often have a huge warning sign is there's a tooth-like ache in the patient's thigh for a year prior to the event occurring. So important when you're prescribing these medications that you think about that. So for high-risk residents, we said suggest because the cost of teriparatide is so high and there's no real evidence around hip fracture reduction. However, it is a very effective option. It's a daily injection for patients who have had vertebral fractures that are painful, especially. And it's the only drug that we have that's anabolic that builds bone. Some of the private insurance will cover it, and if you have an atypical hip fracture, the government will cover it. So for high-risk residents, we suggest not to use etidronate or raloxifene. Etidronate has no evidence for hip fractures, and raloxifene can be associated with leg clots. So in terms of back to the quick reference guide, that this is a really handy tool that long-term care has found very helpful, is the resident, and this is really for all frail older adults, have greater than 1 year lifespan. Is the creatinine clearance greater than 30 mils? If it is greater than 30 mils, then your bisphosphonates are an option. If it's not, then you can look at a denosumab. For those who have swallowing impairment, then look at denosumab or zoledronic acid. And in summary, what does this mean? And this is where the numbers really do speak up. You'll have a probable reduction of 25 per 1,000 fewer hip fractures, 100 fewer spine fractures, and 20 non-vertebral. And what we mean by non-vertebral is that wrist, the shoulder, that we see, the long bones. And these numbers add up to over 200, close to 200 fewer fractures. And often folks will say, well, do spine fractures, are they really so much of an issue? Is often in long-term care, those patients with a curved back that we put in the wheelchair, we sit up for breakfast, after half an hour when they start yelling, anybody with a spine fracture will tell you prolonged sitting or standing more than half an hour is very uncomfortable. And why they want to go back to bed is it decompresses the spine. Not all, but many. And that will happen in even a young person, say with breast cancer, who's had a spine fracture due to osteoporosis. They feel like they need to change position. They can't drive in a car more than half an hour because they have to lie down to decompress the spine or move or shift their position. So how to implement these practice recommendations, everybody often goes to rounds and gets very enthusiastic and says, so what's next? So Vidos actually, Cadith commented on this study. This was done by Courtney Kennedy, one of our JERA scientists, as part of her PhD. It looked at, can we improve calcium and D use in long-term care? Our target audience was the Professional Advisory Committee that includes physicians, nurses, the administrator, consultant pharmacists, directors of care who meet at least quarterly. And what does Vidos mean? We know from knowledge translation that one thing, like me giving you rounds today, is not going to change or improve your prescribing or assessment for fractures and falls. So it included small group interactions, an opinion leader, and often geriatrician, learning modules. The pharmacists did audit and feedback. They gave the benchmarks back to the home and compared them to across the province. And it also included action planning and point of care tools. So action planning, what after learning, hearing what the opinion leaders said, the learning modules, what did the home decide that they were going to do to make things different? We also did point of care tools, which were alerts for the physicians to say, on their quarterly reviews, should this person be treated? So here are what process changes that the homes implemented. Standard ordered admission sets, 1 to 2 staff as osteoporosis champions. The alerts were very effective. So, just overwhelming the physician with paperwork or computer alerts doesn't work. But when the pharmacist, nurse, and the physician met together, reviewing those alerts was effective. And then dietary enhancements for the residents was also the implementation that worked. And we had great attendance and audit and feedback and action planning. This was a CHR funded grant. And so really going back to what's most important is this lady, and you can see when I said about the assessment, look where her neck is sitting compared to her body. It's sitting right here. She's had a number of spine fractures. She ended up in acute care on a number of medications, became delirious, ended up in long-term care, losing her independence. So really this frail older adult, we've already seen in Ontario with the osteoporosis strategy, implementing these assessment recommendations has reduced hip fractures in the frail older adult in long-term care. And the goal is, can we translate these into the community as well for that frail older adult that we see in our clinics and in home care? And we know from the evidence that we can, because it's happened in the frailest of frail in long-term care. So I'll stop there.